Good evening and welcome to the Rural Medicine Grand Rounds. I'm Dr. Lucy Ingram. Tonight's case is on acute psychotic presentations in rural general practice. Discussing our case tonight, we have Dr. John Hall, the Medical Superintendent and General Practitioner in Oakey and Medical Educator with QRME, Griffith and UQ, besides many other things. We have Mr. Craig Mattocks, Allied Health and Senior Psychologist with Medici Allied Health and Senior Psychologist with Queensland Health. Thank you. And Mr. Harry McCay, Head of Professional Conduct at AVANT Queensland.
Evening,
Hello,
Lucy.
Harry.
How are you?
Could we please welcome our expert panellists tonight? As usual, we are being live streamed around Australia. We have a number of participants watching remotely, so I encourage you all to join the discussion by emailing your questions to grandrounds@qrme.org.au, or you can use the hashtag now on your screen. Our presenter tonight is Dr. Brendan Thompson from the Lockyer Doctors in Gatton and Laidley. He's presenting an interesting case on psychosis in rural general practice. Please put your hands together for Brendan.
Thank you, Lucy. Hello, everybody. I like to keep things simple, so we'll see how we go. So psychosis is not something you see a lot in general practice. Basically, we all know what psychosis is. A distortion of thoughts, perceptions, or an emotional response to that. We all know what it manifests as in clinical practice, and that's delusions and hallucinations. So I guess the big three with regards to defining them in clinical practice would be schizophrenia, bipolar affective disorder or mania, and schizoaffective disorder. And I'll show you, we all love epidemiology, so I'll show you some graphs in a minute. But I guess what you can see is that the peak onset is young adults to middle age, males more than females, from a low socioeconomic background. More than half have multiple episodes, and around 3/4 need inpatient care. So I'll bore you with some graphs. As you can see, the predominant one is schizophrenia, followed by bipolar and schizoaffective disorder. These graphs come from a survey by the Commonwealth Government called People Living with Psychotic Illness in 2010. There's some demographics you can see there. So there's the age graph. So as you can see, a lot of people in young adulthood and middle age. And as you can see, most people have multiple episodes with some recovery in between, or multiple episodes with good recovery in between. And as you can see, the predominant number of people have require inpatient care, up to about 3 months duration. So basically, in summary, we've got a 55-year-old lady who presented with those things: pressured speech, flight of ideas, erratic behaviour, dressing up as a lady that, a fictitious character, basically, that was out of context to her mannerisms normally. Severe psychiatric history with severe personal trauma. Legally, an ITO is invoked. And we've got a diagnosis of bipolar affective disorder. So, follow-up with this lady was psychiatrist in Ipswich, myself, to look at her medications. But where to with these people for long-term follow-up and the prognosis? So I guess that sort of is a bit of a snapshot of a bipolar presentation in general practice. I guess I didn't really go into the details of what I did, but she was admitted to hospital by a friend, and we talked a little bit before about confidentiality, which I found having to sort of get the collateral history from a friend was very important with that. And I think Harry from AVANT will probably talk a little bit more about legal aspects of psychotic illness a bit later. But it did put me in a bit of a quandary as to, the risk or potential risk versus confidentiality. So there's the reference to that study. And thanks.
Thank you for your excellent case presentation there, Brendan. Perhaps if I can start with you, John. There is some difficulty in managing patients with bipolar affective disorder. And can you sort of comment more on that in your experience as a rural GP, how you go about managing these patients in your general practice?
Yeah, look, it is always a challenge. I think one of the other symptoms that's difficult that feeds into this is the paranoia that they sometimes express and how to manage that and how they're targeting that towards some of their family members. It can be complex diagnosing these conditions as a GP in isolation and also looking at what are the best medication regimes for them. So my advice to registrars is to make sure that you involve your multidisciplinary team early on, that if you're not sure about something, that you take advice early. But by the same token, if you do have experience in mental health and you've worked in mental health and you feel confident, not to be shy to prescribe antipsychotics if you're confident that you know that that's appropriate in that setting. In the meantime, making sure that you do involve referral to psychology and psychiatrists, or even again using those colleagues via the telephone. So I commonly, if I'm in a difficult situation, won't wait to refer someone on, especially if you know there's going to be delays and there's a tyranny of distance. I would get on the phone, while the patient's in the room often, and discuss the case, and not be afraid to admit when you don't know, and be open with patients. And that's a practice that I do across the board in medicine. I think one of the challenges of rural medicine and general practice is we can't be experts at everything, and often patients appreciate it if you are upfront about not knowing, the nuances of a new treatment or not being sure about something, and being willing and open to take advice and using your knowledge and your skills as a doctor to then communicate the situation to a specialist or involve a psychologist in the treatment locally.
Thank you. Yes. So if I can just ask you, Craig, because working for ACT as you had been, you'd be on the receiving end of some of these referrals. What sort of things do you look for then in those kind of referrals, and where do you go from there?
Basically, the information contained in that case study would be very helpful. Basically the presenting complaint. What are the concerns that you're seeing right there? Why do you feel as though you need to make that referral to mental health? Listing the symptoms can always be very, very helpful as well. Obviously, a bit of a history would be nice to understand if we're looking at a chronic concern or if this is a sudden onset. What's happening with that? That would be helpful as well. Current treatment, medications, are they on anything that might be slowing them down at the moment or contributing to the psychotic phenomena or anything like that? And of course, is there any suggestion of substance use or alcohol use or anything like that? So those are the sorts of things, the general information we'd like in a referral. Obviously, GPs, doctors are quite time constrained, and we wouldn't expect to have a lengthy 3-page dossier of what's going on, but some information is very, very important. The non-urgent ones, when you're making referral to your local mental health service and things like that, one of the key bits of information that is highly valuable is actually correct contact details. That believe it or not, that can be a stumbling point. Quite early on, we try and contact the individual with little luck. Urgent referrals, though, obviously we would really appreciate what is the urgency, identifying why you feel this is urgent, and usually that's contained around risk. They're afraid something's going to happen, or hurting somebody else or themselves, and we'd like to have a bit of information with regards to that. And then, of course, if any involuntary paperwork or anything like that's been done, very useful to have that information sent through before we actually see the client. That's for the after hours and things like that. But for the non-urgent standard referral with those sorts of information, is very, very useful. Yeah.
So you did mention risk assessment, so I might sort of bounce that first to John to see what you think sort of with regard to for seeing the patient first off in the general practice, how you would do a risk assessment and what are kind of the red flags for you. And then we might pass it on to how at ACT you guys do a risk assessment and go from there.
Yeah, look, most of the challenging psychotic patients I've seen in rural areas in my practice have been in sort of more the emergency department context. And they're the ones where I guess that you've got to get the risk assessment right. These are the people where you don't want them leaving if they're a danger to themselves or others, or they're clearly behaving in such a way that they're not in control of their faculties and they are behaving erratically in such a manner that they're not safe to be left alone in the community. In that context, I think it's often when they're florid, it's pretty clear that they're high risk, and I think it is around those issues of suicide assessment and risk of harm to others that were mentioned in the previous case. I think it's very important to remember that we are backed up as doctors and in the system by a Mental Health Act that does enforce further assessment and treatment, and that can be really useful. As a rural doctor, you may in the past people may have felt a bit vulnerable that they've got to risk assess and manage a patient locally and have no recourse to transfer or have resistance to transfer. But with the current Mental Health Act, if you do a risk assessment and you feel that the patient does need to be assessed by a psychiatrist urgently, that you can do the recommendation and the request for assessment, and you can make sure that that person does get transferred to have assessment in a timely way. In those contexts, there's a lot of issues for rural doctors around the complexities of transfer. And getting people out of your town and how that happens. There's also a lot of issues around risk to yourself and risk to your staff and how do you keep the situation safe. And some of that comes down to the techniques that we use for controlling people with medication safely and also physical restraints, which are more commonplace in acute mental health units but still need to be within the toolbox and the skill set of a rural doctor. And for mine, that's really, really important for our registrars to get their head around that, because often they're emergency type situations where you don't have time necessarily to ring around for advice. So it's good to know what doses of medications that you're going to use for sedation or calming people. And it's also good to have some ideas around how you're going to approach these people and what sort of other safety measures in terms of who you're going to have in the room. In big city hospitals, you've got access to lots of wardies and often trained nursing staff and mental health staff. In a country town on a night shift, you might just have a wardie and one nurse, or often an elderly wardie or a female wardie, whereby the issues of having that good physical restraint is not there. So thinking around using your ambulance services, your police and other people, getting them in early if there's issues around safety. And there's a lot in the rapport building, but I think we're going to talk about that a bit later. And in my experience, and the more experienced I became at managing this, I found I had to turn to physical and chemical restraints less when I got better at building rapport with these patients and coming up with other strategies that weren't so invasive, and found that further on in my career I was turning to those sort of strategies less and less.
If I may, Lucy,
Yeah.
just with regards to Mrs. W, I didn't elaborate on it earlier, just about with the initial presentation of this manic episode, about the moral quandary of being a GP registrar, thinking, what am I going to do next? And with regards to the Mental Health Act, with regards to police, with regards to safety of the staff. Fortunately, with Mrs. W, safety of the staff and myself was not an issue. But, trying to not enforce the Mental Health Act was definitely my number one priority. But it's very difficult to get through to someone who is acutely manic because they have absolutely no insight into their condition. And then you've got to weigh up the risk of harm to self or others. And then, obviously breaching confidentiality, I phoned her friend who also worked in the local radiology company And, then that's the other issue with small towns as well. And then eventually, I asked her, do you think Mrs. W is okay? Well, actually, doctor, no, I don't. I'm so glad you rang. For the past so many weeks and months, this has been happening. And, and family and friends are in a difficult situation too, because they don't know what to do. They don't want to call the police or do anything drastic because it's their loved one or their friend. That's a very, very dicey situation sometimes.
Yes, and I mean, do you mind if I just bring Harry in here? Is there much in the way of litigation that occurs after the fact when the ITO or the Mental Health Act is brought into place in these cases of psychotic patients that have no insight? Does that occur commonly?
I'm not sure about how commonly it occurs in relation to the number of presentations of those patients, because we only see the ones that bring a complaint or bring a legal claim, but you do see them from time to time. We have patients. We had one just this year who wrote to the medical board and made a complaint from a ward where she had been admitted under an ITO, and was saying, I've been unfairly diagnosed and involuntarily treated. Now, of course, there is a whole regime under the Mental Health Act for patients who don't accept the diagnosis and the treatment plan, and they can go to what's called a mental health review tribunal, which is an experienced doctor and sometimes a legal person, and argue a case as to why they should be released from an ITO. But they're often not satisfied with going through that process, and generally they don't have an insight as to the fact that they are displaying signs of quite significant mental health conditions, and then they'll go on and make a complaint to the medical board or to someone else.
Do those complaints typically get up, or...?
No. Generally, in my experience, it's simply a matter of demonstrating that the doctor has a significant concern based upon taking a reasonable history. You don't want to, of course, jump the gun and be trigger happy, as Brendan said, in using the Mental Health Act, but if you have a reasonable belief that the patient is displaying signs of a significant mental health condition, and really the test under the Mental Health Act is it likely that they will pose a threat to themselves or to others, and if that's satisfied, then you can act under the Act.
Thank you for that. Yes. Did you want to comment at all on your experiences working with ACT and having to be a part of that, where the ITOs are enacted?
Certainly. Very much going back to what you said, it can damage rapport very, very quickly the moment you sort of force somebody into something they certainly don't want to be doing and have no insight into it, particularly when they're highly aggressive and you're getting yourself into those sort of situations. So developing a decent rapport with somebody is very, very beneficial. Going back to your comment about the community and the families and friends and not knowing what to do, often one of the barriers to them actually acting on a justice examination order or anything like that is that fracturing of the relationship with the person. I don't want them to know, or they're going to know it's me, it's going to damage the relationship, and so they are very reluctant to actually engage that. So once somebody moves from voluntary to involuntary, it's a very big step, and it can be quite damaging for that person in many ways. So yeah.
Yeah, and I think, John, you were prepared to talk a little bit more to the registrars about how they can go about developing some rapport with these patients, particularly sometimes these bipolar patients can be a bit difficult to develop that kind of rapport with, or patients that have concomitant perhaps personality disorders and things like that, along with their Axis 1 condition. So, what sort of, from your experience, can you recommend to our registrars?
I think in the first instance, and certainly in the general practice setting, it's really, really important to listen, to actually look at the clock and let people talk. And we talk about that often in general practice across other disciplines, but I think it's really, really important to actually listen to their concerns, engage them positively, give them positive feedback, and that you're actually listening. So really active listening is really important in terms of that rapport building and giving them time. I mean, one of the challenges in a busy general practice, especially in the country if you're understaffed and you've got workforce issues, is that you might be booked 5 or 6 an hour, and it can be really challenging to actually set aside that time. And there are situations where you just have to bite the bullet and spend 20 or 40 minutes with someone and catch up or miss your lunch or whatever. But I think giving that time, especially if you don't know them as well and it's an earlier consultation in the relationship, that time is really, really important. With respect to more acute patients in emergency departments, I think one really interesting trick with them in terms of building rapport is being sort of the good cop in the situation. Often these people are brought in under an EEO by the police or by the ambulance, and it's quite a heightened emotion situation. I find it's really good to take the patient away, make sure that you're still in a safe situation if it's an acute situation, and you've got people around you that can support you and you're not locked in a room so that you're potentially putting yourself at harm, but sort of take them a bit away from the crowd and away from the police, get alongside them, let them know that you're there to help them and support them, that you want to help them. Often I find using the Act and the Mental Health Act as bad cop, or in terms of, you know, there is a system in place and there are rules that we have to follow as doctors that are out of our control. There's certain things that we have to do and we're obliged to do with you if we think that you're at risk. So having those type of conversations with them and letting them know that you're there to help them. In those sort of situations when I've spent some time with them and they're sort of looking to you as a friend, as a support person, when you then go and offer them some form of medication, and you offer it in the sense that you want to help them settle down and feel better, then often they'll take it. So in a lot of those situations where you might need to use a sedative or an antipsychotic acutely, you can get to the point with them where they actually accept that as a voluntary thing. And I think that's the ideal way of going about that. But, you know, going back to the GP setting, I think it's about doing a thorough assessment, spending, you know, some good time with the patient. And we've got really good frameworks in general practice and certainly through Medicare around the GP mental health assessment and treatment plans, where you've got a good pro forma of thorough assessment, including your mental status examination and good history templates, whereby we can take a good history, make sure that we're ticking all the boxes and not missing anything out, encapsulate a risk assessment in that, and then you know, that goes through Medicare, gives people access to psychology, allied health, and then linking in your acute mental health service or the private psychiatrist as needed. So, yeah.
Yeah, and thank you for bringing up those mental health care plans. I was just going to ask our psychologist how you feel about the use of these care plans, you know, having taken off since they've been brought in, and particularly with regard to patients with psychotic illness.
Absolutely. Within the private area, I don't see as many psychotic clients as I do within the public area. Clearly, with the statistics that were shown earlier, the demographics are different for the psychotic clients. With the schizophrenias, they're often on pensions, which obviously accessing Medicare through those care plans is very, very helpful and can be an assistive step into getting them into to support, simply because of those financial constraints. I do have difficulty with regards to following clients with schizophrenias or bipolars over the longer term. Clearly, the 10 sessions that are the maximum of 10 sessions that are available, 10 hours a year is not much to be able to assist somebody with such a debilitating diagnosis. Obviously, you're not just dealing with the positive symptoms of schizophrenia and psychosis and allowing the person to manage those a bit more effectively, but you're also dealing with the negative impact, the negative symptoms that impact from those diagnoses as well. So that there's significant dysfunction in many occupational sort of domains and functional domains. So it's a very difficult sort of population to work with under the constraints that with the 10 sessions it is very difficult to follow up and get some lasting change. I mean, these are the chronic illnesses. They need that ongoing follow up. So yeah.
Yeah, that's good. If I can change tack now, something that came up in this case and in the earlier case was substance use. And I just wondered if I could get your thoughts, perhaps, John, on how important it is to get that history from the patient early on about substance use in psychotic presentations.
Look, it's very, very common in my experience, and often, certain substances can cause a significant increase in symptoms. There's certainly things like marijuana and, certainly alcohol. They're the two common ones that I see in my practice, and it's exquisitely important. I mean, it's part of a good, thorough GP history, and our software that we use, most of the software that we use for cataloguing our patient histories has got places where you can document alcohol, drug and smoking history, and I think that's a really important thing that we should be doing with all our new patients anyway, but super important in mental health. And part of the multidisciplinary team in managing mental health is services like ATODs, and looking at really targeting the substance abuse. Often I've found when I drill down into the history of these patients, they're substance abusing because they're trying to treat themselves. So often I might see someone who's presenting with alcoholism who's actually got a mental illness, and they're actually trying to treat their depression or their bipolar with the alcohol to block it out. And often when you have that discussion with them as well, they sort of feel a bit empowered that, they're not just a bad person that's, being judged or abused for their substance use, but you actually having some empathy with them and understanding that they're actually trying to dull their own pain, and that's part of it, and you want to help them get out of it, help them to understand that, whilst they get some short-term relief from the substance abuse, that it's actually playing into their disorder and hampering their recovery. So I think that's a really important conversation to have with them, and not be shy to link in with your with other services that are more targeted at dealing with substance abuse generally.
And as a follow-on question there, does their substance use impact on their risk assessment?
Oh, certainly. I think people that are, acutely affected by alcohol and drugs like marijuana are in a very high risk category for committing suicide or harming others. And often, these acts are completed in states where people are using or have used substances. So I think putting that into the mix, knowing someone's a heavy user of these substances does make you a lot more concerned, and I guess would put someone into a high risk category for me, and would lower my threshold for holding them against their will or treating them involuntarily.
Yeah, and Craig, and would you agree with most of those comments about substance use?
Substance use is very much a common denominator in a lot of psychotic type presentations, schizophrenias. And I agree with John, often when you get to the bottom of it, they're self-medicating. It dulls the voices for a little while, it slows them down for a little while, or speeds them up. But very much, when doing a risk assessment, it is vitally important to determine whether they're actually under the influence as you're doing the risk assessment, or if there's a history of them turning to substances to cope with their symptom profile. And that certainly elevates the level of risk, without a doubt. Yeah.
I do have another comment on concomitant substance use, more in the acute setting. I've been caught out a couple of times where someone's been acutely intoxicated, and I've tried to refer them through to psychiatric services, and they've been bounced straight back because they've been deemed to be sort of intoxicated, not have a mental illness. So I think it's really important that you do a thorough medical assessment and make sure that the person's not acutely intoxicated, that you've let that wash out of their system before you then refer them on. So in a rural hospital setting, there's no reason why you can't, rehydrate someone, manage them medically, settle them down if they're acutely intoxicated, then reassess them when you feel that they've come down off of that, and then refer them through the system. So I think if you try and sort of get out of jail free and turf them early while they're still acutely intoxicated, you'll often find that they'll get to the other end and be straight back in your ambulance to you because mental health doesn't like dealing with acutely intoxicated people, understandably, that, you know, they can't really assess them properly. So that's just a word of warning that, you know, you do have the freedom and in rural areas to use your hospital systems to help people in those sort of situations and monitor them.
On the theme of substances, but just taking a bit of a tangent, is there any sort of role for complementary or alternative medicines in the treatment of patients with acute psychosis or with psychotic illness?
Look, I think we need to have a holistic approach to this, and I think a lot of that involves making sure that they're generally medically well, that you've assessed them thoroughly and you've ruled out serious medical illnesses that might interplay. Again, with the mental health system acutely, if someone's generally medically unwell, they need to be managed and sorted out before they go through the psychiatric system. So, and rightly so, I think psychiatrists like people to be medically stable. In the GP setting, I think it's really important that if they do have concomitant illnesses like diabetes or heart disease or other things that, like specifically pain, which we commonly see in mental health disorders, that you manage those physical disorders well as a part of managing the mental illness. In my practice, I don't use a lot of specific complementary medicines for mental illness. You know, there's certain complementary medicines like St John's wort that's useful in depression, has some evidence. Certainly, I think in people with significant mental illness and some of the negative symptoms of schizophrenia and lack of motivation and anhedonia and depression, often these people aren't eating well, they're not exercising, so they don't have the motivation or the means to live a healthy life. So I think encouraging that healthy living, often I'll recommend multivitamins in the context where I feel that they don't have a good diet. I generally don't recommend multivitamins in people who are healthy and can show that they're eating well, but I think in these situations where you can prove that they really don't have a good diet, that they have a role there. I think there's some evidence for antioxidants and fish oil and things like that in some of the psychotic illnesses, but I personally don't use a lot of that sort of specific complementary medicine. I think you know, really good psychology treatment and the appropriate specific psychology treatment, be it cognitive behavioural therapy or whatnot, is all part of that concert, and making sure that you're utilising the full multidisciplinary team in that context is all part of holistic and, I guess, complementary care.
There's I think the flavour of the month is vitamin B12 and mood disorders. But I think the evidence is very sketchy.
Yeah, that is one that comes up quite a bit.
Yeah.
I think this group of patients are very vulnerable, and they're vulnerable to marketing, and there's a lot of inappropriate marketing of things like megadose vitamins and certain things that, you know, that really don't have evidence. So I think it's really important to caution your patients to actually have that discussion with you about things that they might be taking, and be open and frank about it, and just make sure that they're not wasting money or doing things that, you know, might be unhelpful or might actually interact with the prescribed medicines that they're taking.
Yes, very important there about the interactions as well. We've had a couple of tweets come through. One is with regard to confidentiality, which did come up again a few times in this conversation as well. If you can just comment a little bit more, Harry, on in the case of psychotic illness, when it's appropriate to breach that confidentiality, say for getting a collateral history from friends and relatives.
Well, it's interesting, the Privacy Commissioner has actually issued a directive to exempt doctors from certain parts of some of the privacy principles. For instance, the National Privacy Principle 1, which talks about collecting information, says that if you receive information about a person from a third party, you have a duty to tell the person that the information relates to that you've received information about them, and they can access it if they wish to. But the Privacy Commissioner has made a specific ruling for doctors on the application of a doctor from the AMA to say that they don't have to inform the patient if they get collateral history from a third party. I think in AVANT's experience, it is always good to try and start off by getting the patient to consent to and in fact participate as far as possible in having the family members or the friends involved, so that they don't feel that there's something that gives them more paranoia, some conspiracy against them. So as far as that is possible, I think that's the first step to take, is to try and make sure they know about it and are happy about it. But if there are circumstances where someone rings up and says, I know that my wife, my husband, my child, or whoever it is coming to see you, but I think they are not telling you the full story. Have they, for instance, told you that they were convicted of a drink driving offence last week? Have they told you that, they were found with a marijuana bong or something? I think that information is quite reasonable for the doctor to receive, and the Privacy Act would allow them to receive that. And then they have to work out, well, do I challenge the patient with this information if it hasn't been presented to me? How much reliance can I place upon it? It's a really tricky area, and of course you should, if you're not sure, talk to senior colleagues and talk to your medical defence organisation, which hopefully is AVANT, and get some guidance about that. We had a case that has only just come in where a family member was very concerned about his mother. She'd been in a marriage for 40 years. Her husband had died, and she had met someone online from the United States, and he told her that he was being hounded by the mafia and they were going to kill him unless he paid them a significant portion of money. And she'd apparently put in a place, she'd put a house on the market to sell so that she could send him a very substantial amount of money. And the son was pleading with the doctor to write to the guardianship tribunal and ask them to have someone control her affairs until this could be sorted out, which he did, but now she's complained that he breached her privacy, and so we're in the process of preparing a response to that. But it's an example of, it's good in that case to say, well, I spoke to my colleague, I got some advice about it, and after careful consideration, I took the step that I deemed in the patient's best interests.
A hard one that I deal with a lot is a husband and wife, and they've both got mental health problems that is because of the other person, and I treat both of them. That's very difficult because one tells you all the bad things about the other person, and then the opposite happens, and you're sort of stuck in the middle. Yeah. And you know that they hate each other, and that the crux of their mental health issue is the relationship. And then, oh yeah, Joan did say that. Oh, you can't say that. It's very difficult.
But perhaps you'd like to give some of your personal sort of experience there about being secret keeper as a GP stuck in the middle of a community or a family who will come to see you. Look,
my approach to that sort of problem with conflict within partnership is getting them both in the room together. And I think that's the best way to deal with that, is actually have that conversation with them both there. They're both hearing what each other's saying, and in the sort of relationship counselling type way, you can then confront those issues head on. And I'll often encourage them to see their psychologist together. So with those sorts of confidentiality issues, it's a huge issue in rural towns. And there's been cases where doctors have been successfully sued. One particular case comes to mind whereby they were at a social function in a neighbouring town, and it came up in conversation about a particular patient that was easily identifiable, even though they didn't use the name based on what they did. They were the only taxi driver in town, and in that conversation, something about a mental illness or STD, and that got back to the patient, and that doctor got successfully sued. And that was in neighbouring towns. So, you probably have lots of experience with those types of cases, but it's just really difficult as a GP in a country town, and I think you've got to be very aware of it. You've got to be very aware of the conversations that you have downtown, in the supermarkets, in the corridors of the GP practice, around your reception staff and nursing staff, because everybody knows everybody. We pay close attention when we're orientating our staff to the practice around the issue of confidentiality and those sort of corridor conversations, and also the conversations that are had at the front counter between the reception staff and the patients. Often, there's a waiting room full, and we make special attention to make sure that receptionists don't have clinical conversations or don't get involved in sort of history taking with the patients, so that they're not exposed to confidentiality issues. So I think these issues are heightened in the small, tight-knit communities that we work in, and it means that you've got to be more aware and cognizant and be more careful around the issue of confidentiality, certainly.
Any further comments, Craig or Harry?
Well, can I just jump back a couple? Just as an example, in the acute emergency situation of perhaps, I think, we've discussed trying to find creative ways to manage the patient without resorting to the Mental Health Act. I just want to counsel people not to do what one doctor did, who had a complaint made, was one of the few mental health complaints that was upheld by the medical board. But the complaint was that the patient had been admitted and was felt that the patient needed to take some medication, and the patient was refusing to take the oral version of the medication. And so the doctor said to the nurse, "Please get me the largest syringe you can find with the largest needle," and then said to the patient, "Well, you have the option, you can take the oral medication, or I'll have to use this syringe to administer the medication," and which I thought was, in the circumstances, creative, but the medical board thought that threatening a patient with something you didn't intend to really perform was not professional practice, and so they reprimanded the doctor. So that was just a point I wanted to say. Don't be too creative. In relation to confidentiality, I think the points are that, as far as possible, try and do everything with the patient's consent, and as has been mentioned, or John's mentioned, get people involved in the same room and get them to speak to each other. If you believe that you need to pass on information or receive information, and it's for protecting the patient or trying to avoid harm, then I think that the Privacy Act and the Mental Health Act will give you some protections in that sort of a circumstance. Talk to colleagues about, is there some way to manage the situation without breaching confidentiality? Talk to your MDO.
Thank you.
Just like to say, when clients do come in through the A&E, they're often under an ENO, floridly psychotic, and under the influence, or they're not providing sufficient information. Obtaining collateral is vitally important in understanding what's going on, and I think you pointed it out when you contacted a friend and said, have you seen Mrs. W lately? And usually there's a lot of information that just is delivered without necessarily being asked or disclosing any sort of personal information about what's going on for the client there and then. Often the people around them have seen the symptoms and the decline or the relapse, and are often grateful for a voice to be able to say, yes, I'm extremely worried about Mrs. W or Mr. X or whatever. So yeah, obtaining that collateral is, particularly when people are psychotic or under the influence or whatever, is very, very important. Yeah.
And Lucy, just the other thing I wanted to add is, I think if you're not sure and you're going to err, it's always better to err on the side of trying to avoid harm and wearing the person being upset about confidentiality than trying to protect confidentiality, which might result in some more serious harm.
Thank you. Yeah, that's been very useful. We might have 1 minute for a question if there was something burning in the audience. Otherwise, we might wrap up. Just the one?
John was talking about St John's Wort, And I was just wondering, are there any concerns, say a patient comes to a surgery and they're taking St John's wort and they haven't disclosed it to you, or perhaps they have, and you've decided to put them on an SSRI or one of those similar type antidepressants?
Well, my understanding is that St John's wort works in a very similar way to SSRIs, and you run the risk of problems like serotonin syndrome and issues like that if they're double dosing. I generally don't use it much because I find it's better to use an SSRI, know your doses and know your predictability of your medication, rather than some of the uncertainties around dosing and bioavailability with some of the complementary medicines in that space. So it's vitally important to know what they're taking, and that's what I was sort of getting at before when I said a good complementary medicine history is really important, and not being too judgmental, because if you're like that, then they won't ever talk to you about it. So it's good to be very open-minded about complementary medicine, make sure that you're taking a good complementary medicine history in mental health cases, certainly, but be open-minded and willing to use it. So if I had a patient that refused to use prescription antidepressants but was open to that, then they would be a good candidate for using that in that context, I feel. So, it's about being open and doing what's best for the patient in the context and what they're willing to accept as part of their treatment plan.
Great question there, but unfortunately we are now out of time. So thank you to Brendan for his excellent case presentation, and thank you to our expert panel for their extremely valuable contribution to tonight's discussion.